and then we can get started.
Good morning or good afternoon, everyone. I'm Ashley Harrell. I am a Senior Program Advisor in our Behavioral Health Division at the Medicaid Agency. Thank you for joining us today. And Dr. Morgan?
Sure. Hi, everyone. My name is John Morgan. I'm an internist by training. I'm the new Chief Clinical Innovation Officer at DMAS, and I work closely with Andrew Ashley and our Chief Medical Officer, Dr. Bacciaretti.
So thank you. And so as I'm sure you know, the purpose of today's webinar is to both explain and describe some of the evolution of telehealth policy that we envision that is currently posted for public comment, and as well as field any questions that you as participants may have on our telehealth policy and provide an opportunity for exchange. So with that, thank you very much, Ashley, for this next slide. Just a couple points of housekeeping. For those who could require closed captioning services, those are available. I don't know if the links can be put into the chat function, but if not, they're there in front of you for those who would like to access those closed captioning services, along with some information about how to do so. If you have any issues with that, please put it in the chat and we will be able to address your needs. Next slide. And then, okay, so actually just one last bit of housekeeping I forgot to mention. Please, we will be using, for any of your questions, please make use of the chat function. Actually, I should ask, the Q&A or the chat or either?
We can monitor either. That would be fine, whatever's most convenient for the attendees.
Wonderful, thank you. So please feel free to submit your questions as you have them, as they arise. We will go through this slide deck before turning to those questions, but they will be queued up and we will do our best to address those questions during the time that we have allotted here. By way of context, I believe that we were able to get through most all questions that we had on a webinar, the same webinar that we had yesterday, so please do ask those questions and we will address them, and if not, we will be compiling them into an FAQ format afterwards to be able to address questions that we were not able to during this time. So with that, let's go ahead and get started. Before we talk about the policy, what's in the manual, we thought it would be helpful to provide a little bit of context about how we got to where we are, and just so everyone is aware that really telehealth has been a service that has been reimbursed and authorized for Medicaid for over 2 decades, since 1995. I'm coming on 3 decades almost. This started as a pilot project in Southwest Virginia in 3 localities, 1 psychiatric care facility and 2 medical facilities. And at the time, it was really for a limited set of services, such as consultations, some psychotherapy, and select specialty services. At the time, it was only a limited number of physicians who could provide those services, not other provider types. And its goals were in many ways similar to the goals, some of the goals of today. It was to first and foremost improve access to services for those who might have barriers to that, as well as provide services in a cost-efficient manner in order to reduce costs. Between 1995 and 2014, that was a period in which there were several policy developments for telehealth, such as in 2003. At that point, telehealth was expanded statewide. It included additional services, such as additional evaluation and management services, psychotherapies, and other clinical services. Additional provider types at that in 2003 were authorized to provide services via telemedicine, such as nurse practitioners and nurse midwives, and psychologists, and so on and so forth. 2009 and 2011, additional originating sites were authorized and additional services. And then finally, the last major update was in 2014, which expanded the set of services covered by telehealth, as well as originating site providers. And then finally, in 2019, there was a clarification that, FQHCs in particular could be distant site providers. That took us up until when COVID hit. So the last major policy change for telehealth it's been really several years, over 5 years since, or over 7 years since the last major policy update has went through for telehealth. Next slide, please. So as I'm sure all of you, we are all aware, COVID-19 in many ways unleashed the potential of telehealth. We thought it might be helpful to, at a high level, reflect to everyone on this call what that experience has looked like, at least from where we sit, and the information that we have been able to collect on the use of telehealth since COVID-19 started. In this graph, this runs from July 2019 through December of 2020. As you can see, the use of telehealth up until when the federal and state public health emergency started and when flexibilities were granted in mid-March with Medicaid, excuse me, there was modest utilization up until that point. As many, if not most other states experienced, once flexibilities were put into place, the volume of services delivered by telehealth increased substantially on the order of 15 times greater than it had been previous to the public health emergency, with over 57,000 members, Medicaid members, each month still continuing to receive services via telehealth. So really, it has been a hugely important in maintaining access to services as the COVID-19 pandemic has evolved. Next slide, please. So what do we know about the types of services that our members have been receiving? And I do apologize, the print is a little bit small on these pie charts, but on the left, those were claims coming in from July 2019 right until the eve of the flexibilities that were provided in Medicaid, so through March 18th of 2020. And so bear in mind that if you were to scale these pies, the pie on the left will be much smaller than the pie on the right because there are simply very many services, fewer services being offered via telehealth at the time. Having said that, the vast majority were behavioral health, either in terms of substance use disorder or behavioral health services, a modest amount of developmental disorders, and primarily that would have been speech language therapies, and then a bit of even more modest slice of the pie was going towards other clinical services that were not behavioral health. Since the start of the pandemic, again, all services have experienced growth in volume. But what we've seen is that this has really been something where a variety of service types have been able to benefit from telehealth. Behavioral health services still does account for the majority of services, but non-behavioral health services, clinical services, E&M kinds of visits in an outpatient setting that don't have to do with behavioral health, those kind of services have also been able to take advantage of telehealth to a greater degree than before. Speech language therapy, physical therapy, occupational therapy, and others have also been able to benefit. So really, it has continued to be able to address the access needs of a variety of services and members' needs. Next slide, please. And finally, as we all know, there have been national conversations and awareness of issues of health equity and how that has been played out in various shapes and forms during the COVID-19 pandemic. From the data that we have been able to collect, really, in some ways, telehealth has been a bit of a force for equity. Prior to the public health emergency, as an example, services for African Americans was about 22% of all telehealth services, whereas currently it has increased to 30%. And those of other minorities have also experienced increases. So in many ways, the services that many of the stakeholders on this call are providing are really reaching and able to help those across all race, ethnicities, rural, urban, in order to access those services. Next slide, please. So with that context in mind, what were some of the policies that brought about that increase in volume and what we've seen in terms of the kinds of services offered? I think Yep, that's perfect. So, right. So in terms of synchronous audiovisual telehealth, and that we will equate with the term telemedicine, one of the biggest changes and flexibilities, as I'm sure you are all very much aware, is flexibilities around originating site. Whereas previous, since 2014 in guidance provided at that time, there was a very limited set of locations that could be considered and bill for an originating site fee. Or for members could even be located, regardless of the fee, but be located to receive the service. With the flexibilities, those restrictions were relaxed. Originally, home was allowed as an originating site, but per GA legislation and as the COVID-19 pandemic has evolved, at this point, that is really any location that the patient is located is now allowed as an originating site. So really opening up the possibilities on that front. As well as during our period of federal public health emergency, there have been a broader array of services that are allowed via telehealth, as long as they meet the conditions that have been outlined in a series of provider memos that DMAS has put out. First in March 2009, or March 19th, excuse me. Second in mid-May, I think it was May 15th, and then finally for behavioral health, in the end of September, there was additional guidance provided. So has really expanded that scope. Additional modalities of telehealth were authorized, such as asynchronous or store and forward kinds of activities. E-consults were allowed, provider-to-provider consultations. A key feature that was in Virginia, as in many other states, was the use during this time of public health emergency for audio only, relaxing the requirement to have a video connection, as well as being able to take advantage of certain relaxations on HIPAA and patient, or I guess having HIPAA compliant devices. And so allowing the use of audio only has been a key in terms of maintaining access to services. And finally, allowing for remote patient monitoring for COVID members with suspected or confirmed COVID-19 cases. Next slide, please. So that brings us to where we are right now, and we thought it would be, there's a bit of nuance to where we are now and how the policy will evolve going forward. So I'll take a few moments to walk through how we at DMAS envision telehealth policy evolving, and really the basis of that evolution is what is now, has been posted for public comment on the website, and that we anticipate will be finalized within in the coming weeks once that period is done and we are able to finalize that guidance. So on the left are some of the key telehealth policies, and then the subsequent columns are where how they stand at different periods of time. As an example, originating site. Prior to the pandemic, it was not anywhere where the patient was. It was a limited set of locations. Since March 19th of this year and going forward, it is anywhere where the patient is located. So that will continue throughout. In terms of billing modifiers, prior to the pandemic, the guidance was to use the GT for synchronous and GQ for asynchronous services, and those were obviously required. Since the beginning of the public health emergency up until even today, the guidance has encouraged their use, but hasn't had an absolute requirement about that. Going forward, that will be a requirement is to go back or continue to use GT and GQ to signify services delivered by telehealth. There is a bit of nuance in how that is going, the timing of that, which we'll get to in a couple slides, but do bear in mind that in the near future, for a specified set of services, our expectation is that providers, if they are not already billing using GT or GQ modifiers, will start doing so. And we'll have time to delve into that in a little bit more detail. And then finally, the last 6 rows in the left column are all different modalities of telemedicine and policies in the pre-pandemic period and telehealth. Did I say yes? If I misspoke. Audiovisual, telemedicine, and store and forward. There was a very limited set of store and forward services, as well as other telemedicine services that have been in place since 2014. That currently has evolved as described in the various memos that have been issued, and that will, going forward, we don't know exactly when the public health emergency will end, but the manual that's being posted for public comment right now, it is envisioned as what will last beyond the public health emergency. So everything that is contained in that manual posted for public comment will serve as our new policy, our evolved policy for telemedicine, and again, for those very select few store and forward services going forward. There are a variety of other modalities that were authorized either during the public health emergency, so right now, or for our General Assembly beginning in July 1st. I won't go into great detail on these because that's really not the focus of this presentation. Actually, Ashley, if you can advance the slide. What we want to emphasize is that for today's discussion and for the manual update that you may or may not have seen, but that's posted for public comment, it is these 2 modalities that we are focused on, and primarily it's telemedicine, mostly because there's just a few use cases of store and forward that are included in that policy that were inherited from 2014. So this is what we are focused on today, is policies regarding synchronous audiovisual telemedicine and how we envision that evolving over in the near future. The other modalities that are listed there that have been grayed out, there will be policy developed on that. We anticipate layering in those guidance on those policies onto the telehealth supplement that is being posted for public comment, but for the moment, that is not the focus of either the manual updates or today's discussion. Next slide, please. Did want to provide an overview of what has been posted for public comment and the different provider manual sections that are affected by an evolution of telehealth policy. First and foremost, what we've envisioned is that previously, up until right now, guidance on telehealth is peppered within a variety of different manuals. Our approach going forward is to consolidate all of that into a new telehealth supplement. And that will be the one-stop shop for anything telehealth. For the moment, it contains content basically on telemedicine and those very few store and forward. As we bring other modalities online, whether it's provider-to-provider consultations, whether it's remote patient monitoring, we anticipate integrating that guidance and building upon what is already contained in the supplement to provide additional guidance. So really our idea is a one-stop shop for anything telehealth, and starting with telemedicine and store and forward. Having said that, because there are references to telemedicine peppered throughout other manuals, we have made minor revisions to those manuals. By and large, it has been to remove any content on telehealth or telemedicine that was contained in those manuals and refer the reader to the telehealth supplement. But did want to make everyone aware that that is what you see here are all the manuals that we anticipate revising in some way, shape, or form because they touch on telemedicine, telehealth. Next slide, please. So I know I've said it before, but it does bear repeating. What we're discussing today are revisions related to telemedicine, again, that is synchronous audiovisual telehealth, and a very few existing store and forward services, specifically teledermatology, teleradiology, and monitoring for diabetic retinopathy. And what I can say is we have not touched or altered in any way the coverage of those store and forward services. And to the extent that we are updating telemedicine services, we have not removed any services that are been authorized for telemedicine, but we are simply adding to the scope and to the set of services that can be offered via telehealth, according to the provider manual. There are several key changes I think it's just worth noting what are some of our goals for this update. And in many ways, they're the same. They share some similarities with the goals that were since 1995 in terms of what was envisioned then. But with over 2 decades of experience with telehealth, and especially with COVID-19, really what we're trying to do are 2 main things with telehealth. First is to increase and sustain members' equitable access to services while maintaining and improving quality through coverage and evaluation. But secondly, increasing and sustaining providers' willingness to offer services delivered via telehealth by establishing appropriate incentives and, importantly, certainty about what it is that they can expect to be able to provide. So we consider the telehealth supplement as the basis for achieving both of those goals going forward. The key changes, one has been to expand the range of telehealth originating sites and the types of providers who are able to be reimbursed for services delivered via telehealth. Second has been to expand the number of services authorized for telehealth, and we'll talk in just a moment about what those are. And finally, what we hope is increased clarity on conditions for reimbursement, on billing procedures, provider requirements, documentation, and patient education. Next slide, please. And in just one moment, we will go into some of what those additional services are. Having said that, we did want to speak to the timing of what we envision this evolution to be. By way of context, the federal administration has indicated that the federal public health emergency is likely to remain in effect through the end of 2021. So while we don't know exactly when that will end, we do expect many of the flexibilities that have been in place since the start of the public health emergency to last until that ends, until the federal public health emergency ends. And again, we have reason to think that will continue to last throughout the 2021. So what does that mean for providers? That until the end of the federal public health emergency, certainly providers may and should continue to follow the guidance that has been described in various COVID-19 Medicaid memos. As I mentioned, there are 3 main ones in March, in May, and September that speak to telehealth. The one change that may affect some providers and may not, depending on where their billing systems are, providers will be required to adhere to billing requirements for services listed in Attachment A of our telehealth supplement, and that are not delivered in person within 60 days of the effective date of the policy changes. And the effective date will be when the manual is finalized and published, and a Medicaid memo is issued to alert providers that this updated policy has been published. For some, that may mean change because it's very likely that many providers have already set up their billing systems to be able to bill with the GT or GQ modifiers. For others, that may mean that those providers need to make those changes if they want to continue to bill for telehealth within 60 days that our guidance, our manual is finalized. And then finally, when the federal public health emergency ends, we would then expect at that point in time that providers would be able and ready to adhere to all the sections of the telehealth services supplement, not just the billing requirements. So with that, I think I'll turn it over to Dr. Morgan to walk through some of the additional telemedicine services that we are proposing to add to going forward on the clinical side. And then after that, Ashley can speak to some of the behavioral health services. And again, these are additional to those that have been authorized since 2014, as noted in the slide.
Thanks, Andrew. Appreciate it, and appreciate that disclaimer, which I wanted to reemphasize, which is this is not a comprehensive list, but this is a list that is highlighting the additions we have made for services that will newly be covered post-public health emergency that build on the authorizations that were already in existence since 2014. So to run through this list rather quickly, and then I'm always happy to provide answers to more specific questions. This includes coverage of a range of prenatal and postpartum services. This includes coverage of the bundled codes covering prenatal care, delivery, and postnatal care, or at least the appropriate services that comprise those services. A whole swath of codes around care for end-stage renal disease. It includes coverage of genetic counseling, and I apologize, I'm halfway through this list, but I just wanted to reemphasize, again, to Andrew's prior comment and kind of contextualizing, this is all referring to coverage for delivery of these services via a synchronous audio-visual modality. And hopefully you can hear me over the toddlers in the other room clearly enough. Moving forward, maternal mental health screening, similar to postpartum visit care, as well as a select range of physical and occupational therapy codes that have been vetted semi-exhaustively with a range of Virginia-based subject matter experts and kind of been finalized based on a number of conversations with our managed care organizations, as well as nutritional therapy counseling, a range of nursing facility discharge services. And with regard to evaluation and management, the reason that assisted living setting is specified is that as of our 2014 policy, evaluation and management codes, relating to traditional outpatient and even inpatient services have already been covered via synchronous audiovisual telehealth. And we are adding to that list of codes those that pertain to assisted living settings. A handful of respiratory therapy codes, a number of educational services, and then of course select early intervention services will also all be covered via synchronous audiovisual. The kind of two caveats I'm going to make to this list is at the very top and the very bottom, prenatal and postpartum visits and early intervention services are really the only two services for which we are going to specify additional requirements that are specific to telehealth. With respect to prenatal and postpartum visits, this is simply a requirement that insists that at least one visit per trimester occur in person. This is in keeping with natural best practice and in some ways may be redundant, but because of the sensitivity around this population, we have specified that when delivered via synchronous audiovisual, providers must ensure that that kind of minimum one in-office per trimester visit threshold is met. And then with respect to early intervention services, again, because this is a particularly sensitive population and because the nature of these services by definition requires collaboration with parents, care providers, we have stipulated some additional telehealth specific conditions that need to be met for these services to be delivered via synchronous audiovisual delivery. Next slide. And I'll take a quick pass and then I'll turn the time over to Ashley, who can kind of revisit the nuances, or at least give a brief description of some of the behavioral health services that will also newly be available to be delivered via synchronous audiovisual after the end of the public health emergency. And again, I keep on emphasizing after the public health emergency because during the public health emergency, these two are also naturally all available to be delivered via synchronous audiovisual telehealth. But we flag this as I think a very positive change, which is as opposed to reflexively going back to our fairly limited subset of services eligible to be delivered outside of a public health emergency. These are now newly to be available indefinitely. They include pharmacologic counseling, codes that reflect prolonged delivery of certain office-based services, and a range of psychological, neuropsychological, neurobehavioral, and neurobehavioral testing, evaluation, and scoring services. And they cover, to this last point, both assessments that relate to the individual as well as interventions that can be delivered not only in an individual, but a group and families. Ashley, I'll turn it over to you.
Thank you, Dr. Morgan. In addition, these behavioral health services that we have our new mental health services provider manual that was just actually on public on town hall for a public comment period. That it's combining our community mental health rehab services provider manual and our new Project Bravo services, which is assertive community treatment, mental health, intensive outpatient, and partial hospitalization. So that's all under a new mental health services provider manual. So the services that we are allowing to be delivered via telehealth after the public health emergency is mental health case management, psychosocial rehabilitation, therapeutic day treatment and intensive in-home services, behavioral therapy, including applied behavioral analysis, treatment foster care, case management, mental health, peer recovery support services, and crisis intervention. And then, as I mentioned, the services under Project Bravo that are going live July 1st are assertive community treatment, mental health partial hospitalization, and mental health intensive outpatient services. And then we have under our children's residential treatment services benefit, the IACT initial assessment will be allowed via telehealth. And then we have many services under the addiction and recovery treatment services benefit, which is our Medicaid substance use disorder benefit, which is the arts side of peer recovery support services, smoking and tobacco cessation counseling, screening, brief intervention and referral to treatment, or ASIM level 0.5 or ESPERT services. We have various services within our office, the opioid treatment programs, where our clinics that are licensed by the Department of Behavioral Health that are able to dispense methadone and buprenorphine for the treatment of opiate use disorders, and several services in our preferred office-based opioid treatment model, or OBOT, that have been public health emergency were required to be in person, but we're allowing for several of those services to be allowed via telehealth after the public health emergency. And then we have substance use disorder case management, substance use partial hospitalization, and substance use intensive outpatient. And before we actually go to the next slide, I'm going to see if I can show you some questions we had on the webinar yesterday were, what about services that were allowed prior to the public health emergency? So I've pasted the DMAS provider web portal link in the chat. And when you go there, you select Medicaid memorandums, and then you want to select the 2014 and submit. And then you will scroll down and you'll find here the May 13th, 2014 memorandum that is updates to telemedicine coverage. And if you scroll down to the end of the memorandum, we will have a list of all the codes that were allowed via telehealth prior to the public health emergency that Andrew and Dr. Morgan were discussing before. All right.
Thank you, Ashley. That was really really helpful. And in fact, it that little asterisk, in addition to all the telemedicine store and forward services listed in the 2014 memo, that's exactly what Ashley just presented, what those services, or she gave a glimpse of what those services are. So thank you, I appreciate that. And actually, before you progress to the next slide, one caveat in all this, there are teledentistry is a use case is a subset of telemedicine or telehealth. There is teledentistry policy being developed as we speak. However, the telehealth supplement will not address teledentistry per se. That will be a different policy document. So for any dental providers or those who use and have interest in CDT codes, dental codes, there will be forthcoming guidance on that that is not included in this telehealth supplement or today's webinar. All right, next slide, please. So the way that the telehealth supplement is structured, it first provides some overarching conditions regardless of modality, whether it's synchronous telemedicine, asynchronous store and forward, whether it's remote patient monitoring, so on and so forth. And then to the extent applicable, it provides the modality specific conditions or considerations. So this presents what would apply to any telehealth services regardless of modality. First is that the service is clinically appropriate to be delivered via telehealth. To a certain degree, that is by selecting a set of services and by articulating the set of services that are authorized for telehealth, we feel goes a long way towards ensuring that it is clinically appropriate. However, there may be certain circumstances for certain individuals that at that time that service is not appropriate, and we would expect the provider to make that determination and decide that if that's the case, that telehealth is not the right modality. As an example of kind of obvious examples of when a service isn't appropriate, it might be one that requires a direct visualization or instrumentation of a patient, something along those lines. So again, it is up to the provider to make that determination. Second, that the service is able to meet the CPT and or HCPCS requirements. And if it can't, then it shouldn't be delivered via telehealth. Thirdly, that the service meets state and federal laws regarding confidentiality of information, as well as patients' rights to medical information. This is very similar to what would be in person. Fourth, that the services must meet all applicable state laws and regulations and licensure requirements. As an example, if there is a provider, if a member is in Virginia and the provider is in another state, it is on the provider should make sure that according to their regulatory board, they have the appropriate license. They may need a license both in Virginia and the state that they're practicing. They may not, but that is something that the provider would be expected to be aware of and make sure they're in compliance with before providing a telehealth service. And finally, with the goal that, or with the premise that telehealth is a modality of a service, it's not a distinct service in of itself, but it is in-person as a modality, telehealth as a modality. To the extent we felt appropriate, any service limitations that exist or don't exist for a service are the same for telehealth. There are some exceptions to this. I think Dr. Morgan referenced one. As another example, for prenatal and postpartum visits, according to the manual and what's posted online for public comment, there is a telehealth specific service limitation in that case of at least one in-person visit per trimester for the purposes of evaluation, testing, and assessment. That's really, though, the exception. The norm is that whatever service limitations exist or don't exist for that service when delivered in person would be the same for when delivered via, I guess, telemedicine in this case. Next slide, please. There are some additional telemedicine-specific conditions and considerations that are articulated in the provider manual. First, telemedicine must be provided with the same standard as in-care person. Again, it is a modality. The expectations around the standard of care should not differ whether it is delivered via telehealth or in person. Secondly, telemedicine must not be used when a face-to-face services are clinically necessary, and this may be a case-by-case determination with the provider. And finally, telemedicine, any visit by telemedicine, it must be able to be converted to in-person if it is needed. If a visit is an encounter is initiated, and for whatever reasons, whether it's technical connections, whether it's clear that the confidentiality on perhaps the patient's end can't be maintained, then there is the expectation that that is converted into an alternative form of visit, an in-person visit, and that that wouldn't then be two visits that a provider could bill for, but no, that's all part of one visit, and that was maybe started in a telemedicine modality, but for various reasons had to end as an in-person. Next slide, please. In terms of billing procedures, there is nothing fundamentally different from what has been in place since 2014 and previously. However, the manual does provide additional detail and hopefully clarity on how to think about billing via telemedicine, excuse me. So in terms of telemedicine, continue to use the GT modifier, but now it does provide guidance in terms of place of service. That should be, should not, there is a modifier for telehealth. That is not the modifier that we are asking providers to use. We are asking that providers use the place of service where it normally would have been provided had it been in person. As an example, if the service would have been in an office, then place of service 11 should be billed in that case, which is CMS's place of service for an office. For store and forward, continue to use GQ modifier, and the place of service in this case is where the distant site provider is located at the time that the service is rendered. For originating site facility fee, that may be billed if it is medically necessary for a provider to be physically present with the member at the originating site at the time the telemedicine service is delivered. And the originating site is a provider location, and by provider we mean a Medicaid enrolled provider where healthcare services are rendered, and specifically that does not include the member's residence. That would not be an appropriate place to bill an originating site fee. And one change from previous guidance, whereas providers authorized to bill for telehealth since 2014 have been a limited subset of those able to bill for that service on an in-person basis, that limitation has now been removed. So if a provider is able to bill for a certain service on an in-person basis, then that provider is also able to bill that on a telehealth telemedicine basis or telehealth basis, as long as the conditions articulated in the whole telehealth supplement are met. Next slide, please. And we will end with the content of the memo with this slide, which is a series of other requirements that go along with those already described. First have to do with provider requirements. Providers must maintain, and just to emphasize, by provider, we have in the telehealth supplement, it is defined, and we have a very specific definition of what that means, and it is a billing provider who is either a qualified licensed provider or a facility who is enrolled with DMAS. So the providers must maintain a practice located in Virginia or be able to make a referral to a Virginia-based provider, again, another provider who would be able to provide that Medicaid member a service. In terms of documentation, by and large, documentation should be the same as for a comparable in-service, and what's documented in person is also documented via telehealth. The providers delivering the services via telehealth must maintain appropriate documentation to substantiate the technical and professional components of the codes that were met, and it should be maintained in the patient's medical record. Thirdly, there should be informed patient consent documented in the medical record. This includes, among a description of the telehealth service, that the use of telehealth is voluntary, and that member may refuse to have the service delivered that way. In terms of HIPAA, that dissemination, storage, or retention of an image or anything identifiable shall comply with any applicable federal and state laws. That the member has a right to be informed of who's going to be present at the visit and a right to exclude anyone, and that the member has the right to object to any kind of videotaping or other kind of recording of the encounter. And then finally, there is an expectation that equipment that is used for this telehealth visit must be of sufficient audio and visual quality to be functionally equivalent to in-person. And importantly, that providers have the proficiency to be able to use that equipment as intended. So with that, that is hopefully for everyone here, a useful summary of what is contained in the telehealth supplement. There is I think now would be a good time to field questions. As we do that, Ashley, are you able to advance, I think, 2 slides? So one more slide. For those who are interested, these are all the links to the public comment. It's posted on Town Hall. All of these links are, if you would like to make public comments on any one of these, the documents that are being posted for public comment that have to do with telehealth, please make use of these links. They were posted at the end of May, and I believe it is June 23rd. That is the closing date for public comment, so there is still ample time to go to the site should you wish to make any comments and post it in that forum. And then after that point in time, DMAS will collect those, we'll review those, and then consider those as we finalize our policy for final publication. So with that, I will stop And Ashley and John, if there are questions, let's, I don't know, it worked well to take them in order. Should we do the same thing for today?
Yeah, and I have combined the Q&A and chat questions, so I could just start from the top, okay? The first question, can the originating site be the therapist home after the public health emergency for this one specifically for employees of the CSB, but probably would also apply for private providers too?
So I think the question is, can the originating site be the therapist home, or so let's just clarify. The originating site is where the member is located. So that would be anywhere where the member is located is a valid originating site. However, if they are located in that provider's office, then presumably it might not be a telehealth visit. It might be an in-person visit. Now, having said that, if the question is the distance site provider, you know, the distance site provider should mark where should be where that service normally would have been delivered. So the distance site provider would mark as a place of service where that had that visit taken place in person, where would that usually have been? So if it usually would have been in an office, then that would be the place of service marked for that particular visit.
But just to recap, the short answer is yes, it can be appropriate to deliver services from one's home. The follow-up that you didn't ask but would need to be answered is, what would you list as the appropriate place of service? And the answer would be wherever you would ordinarily evaluate said patient or deliver said service, were you not doing so via telehealth? And to the other follow-up question that Andrew answered but maybe wasn't asked, but which is very important to emphasize, one should never bill an originating site fee, which is separate from the service you are normally delivering. It's a standalone fee that is only ever appropriate when you are using your office traditional location to serve as a launching point for the actual service, be it an E&M code, a behavioral health service, to be delivered by a separate provider. So that may not have been your question, but just to be clear, you know, billing that origination site fee would never be appropriate from a home setting.
Thank you, John. And there are several questions related to mental health skill building and crisis stabilization services that you will notice is not in the slide deck because it's not in the current draft telehealth supplemental manual. So DMAS has received feedback on this and are considering these additional services for going forward in the manual update. So that's a lot of questions around that, but I think that probably answers a lot of feedback we've gotten around the concerns that mental health skill building and crisis stabilization, that you didn't see it on the slide. Another question is, I understand that audio only telehealth ends with the end of the public health emergency and that DMAS is working on new policies around this. So what will audio only option be like after the public health emergency, either the federal public health emergency when that ends or the state public health emergency?
Thank you. This is really tied to the federal public health emergency and some of the federal flexibilities around really OCR related guidance and flexibilities. So after the end of the federal public health emergency, that will be subject to our policy that is in development. And since it's hard to know the timing of that, I can't guess right now whether we will have finalized policy on audio only when the public health emergency ends. If we don't, then at that point, audio only would not be an option until that policy is finalized and developed. If the policy has already been finalized and developed, then whatever that policy is would kick in. Please do, just to reassure everyone on this line, the slide deck referenced additional modalities, provider-to-provider consultations. It referenced audio only, remote patient monitoring, virtual communication, e-check-ins, I believe. And I feel like I'm missing something. Those are all in active policy development. We are taking a thoughtful approach, consulting with stakeholders, with subject matter experts, with other states to plot paths forward in all of those. But it does take time, and so just know that that is in policy development. And as importantly, when we are ready for communicating that. There will be the same public comment process for that. There will be the same 30-day public posting period for those policies. So you as stakeholders will have the opportunity to provide your perspectives on those policies when they are ready for communicating out.
Thank you, Andrew. There was a question about specific CPT and HCPCS codes that align with the slides that we had listed the services. And if you look at in the chat function, there's a link to where the draft provider manuals are posted, as well as a link to Town Hall where we've got the specific telehealth supplemental manual posted, and the specific CPT and HCPCS codes are listed there. Another question, will all behavioral health services that are currently have the flexibility via audio only and telehealth allowable until the end of the public health emergency? And that is yes. And I can tell you that we normally do not get notice of the federal extension of the public health emergency until a day before it is set to expire. It's currently set to expire July 20th, so I would anticipate we'll hear something probably the 18th or the 19th of July if it gets extended another 90 days. As soon as we get that, DMAS will issue a memorandum to alert providers that we will continue to follow suit with that the federal public health emergency extension. Another question, will telephonic only be removed July 1st for behavioral health? Going back to the slide, let's see if I can navigate the wonderful chart that Andrew and Dr. Morgan did. You can see here that the services here in this bucket that we will allow audio, visual, and audio as defined in those memorandums posted for the flexibilities during telehealth on March 19th, May 15th, and September 30th, if that's the right dates, but that's the flexibilities for the public health emergency. Okay, will there be a standard form created to determine clinically appropriateness for telehealth?
No, because in many ways that needs to be made at the individual level for that encounter. Again, our premise is that all the services listed in the attachment A of what's posted for public comment in the telehealth supplement are in many times clinically appropriate. However, there may be individual factors that make it not so at the time of the encounter. So it is up to the provider to make that determination whether all the conditions can be met, not just clinically appropriate, but others can be met at the time of the encounter.
Thank you. We have another question around managed care policies during the public health emergency and post-public health emergency. And the one particular question was, are the MCOs required to follow DMAS's policies during the public health emergency around telehealth? And I'm going to answer, the answer is that the MCO should be following DMAS's policies. If you're experiencing they're not, we do have a data for behavioral health. If you can email enhanced BH, and I will put this in the chat, to let us know, and we can have some staff research that for you. All right, so that is now in the chat function. If folks need to email specifics, have an early intervention question, must the family member or caregiver, trained facilitator, or member of the clinical team physically be present with the member during the visit? And confirming that the member is the child, and I would assume, yes, so usually when we refer the member, it's the Medicaid beneficiary. So the question is, so if a mother is with her child, the member, and the provider delivers the service via telehealth, can that provider deliver early intervention services via telehealth?
John, I think, did you field that question in the chat?
I think I did, and actually, correct me if I'm wrong. So the detail is there are two telehealth specific conditions to delivering early intervention services by telehealth. The first is that I'll just say a responsible adult, namely a care provider, and I'm trying to reference exactly where the question is so I can get it all right. A care provider or a member of the care team or a trained facilitator be present with the child member. So that's condition number one. And the second condition is that outside of extraordinary circumstances, the first visit should be delivered in person. And just to be clear, that's really the only service for which we are allowing synchronous audiovisual coverage after the pandemic, for which we actually specify that the first visit must be in person. All other services at this point do not have such a limitation.
Thank you. We have another question. Please confirm that adding the G2, GQ codes or the modifiers to billing is required 60 days after the Virginia DMAS telehealth policy goes into effect, even if we're still under the federal public health emergency. Great
Confirming
question.
that is, yes, thank you. Just want to, that's a great question, just so everyone can hear. Yes, confirming that is correct. And that that is for the services listed in the attachment A of the supplement. So whereas there may be flexibilities for providing services via telehealth that are beyond those, due to the public health emergency, beyond those services specified in the attachment A, our requirement specifically is for those in attachment, that subset of services that are those in attachment A. But yes, within 60 days of whenever this guidance is finalized and published.
And to add context, in the event it seems arbitrary or capricious, this is an attempt by DMAS to ensure that we are getting reliable, consistent, accurately reported data regarding services that are delivered via telehealth, but we're intentionally only imposing this requirement on services that we know will be available to providers long term. In short, we have tried not to enforce a reporting requirement for services that, where we realize that may not be available to long term, recognizing that it does take effort from an IT standpoint or from a billing system standpoint to come into compliance with DMAS. And so we're trying to only require that for those services where we feel there is definitely going to be a long-term requirement and therefore a long-term benefit, and trying to avoid making any of you redesign your systems only for a very transient period of time.
Thank you. There are a couple more questions around early intervention to clarify credentials of the provider, as well as the requirement of face-to-face versus telehealth. Is that something, Dr. Morgan, would you like to speak to, or would it be good to email the VA telemedicine with the specific questions?
Probably better to email with a specific question.
Okay.
Although while I'm unmuted, I would say I'll take a crack at another question I see, which we've heard before, coming from Bob Horn. Says, can the requirements for telehealth or telemedicine services be different for services billed to MCOs? Must MCOs maintain the same requirements as defined in the supplement? I'll take a pass and I'll have Andrew correct me if I'm wrong. Our managed care organizations are globally expected to make services available to the same scope and duration as DMAS, is our fee-for-service arm. And so it is appropriate and reasonable to expect that MCOs will allow synchronous audiovisual delivery of the same services that we have outlined in this appendix. However, it is possible that MCOs institute additional utilization management restrictions or conditions for delivery of these services. Andrew, please correct me.
No, I think as with anything, certainly it is best to get in direct contact with the MCO to understand their policies and how for telemedicine. And if you have any future questions or concerns, again, can we put the VA telemedicine email in the chat? Please get in contact with your MCO and if need be with DMAS, but always refer back to your MCO or NCOs for their specific policies for members covered by them.
Vicky, another question. Can you clarify the difference again between the GT and the GQ modifier?
Sure. My suspicion will be most of those using telehealth will be using the GT. That refers to synchronous audiovisual. What we, consistent with CMS, we are calling telemedicine. GQ would be an asynchronous, what is commonly known as a store and forward service. Such as a primary care physician gets data like a radiology test from a image from a patient, or in some cases a patient might be able to communicate some data directly to a distance site provider. So that information, that data is transmitted to a specialist for reading perhaps. At a different point in time. So like, let's say a patient comes into an office, gets a radiology test or exam, excuse me, and that data will then be transmitted at a later point in time to a specialist who then reads and interprets that and provides their assessment back to, say, the PCP, who then relays those findings and that interpretation back to the patient. That would be the distance site provider. In that case, would be the specialist reading that, providing that interpretive service of that radiology exam. But it took place, 2 hours later, 2 days later, whatever it may be, and did not take place at the same time. So that is the instance in which the distance site provider would bill the GQ modifier for that service.
Thank you. And I think, Dr. Morgan, you may have answered this in the Q&A regarding slide 20. In a situation where a facility is licensed and physically located in Virginia, enrolled with Virginia Medicaid, can the telehealth provider be located out of the state physically as long as they are also licensed in Virginia and enrolled with Virginia Medicaid?
Yeah, and the answer in short is that Medicaid DMS does not have policies stipulating where a provider must physically be located when they are delivering the telehealth service. And so the answer is there's no restriction on where the provider must be located, assuming they are licensed by the state, enrolled as a VA Medicaid provider, and if they are working with and their typical location of providing services would be at a location that is within the state.
But just to put a caveat on that, Ashley, if you could go forward before the slide, I don't know which slide it's on. Oh, right here. But just do bear in mind that if they are out of state, if it's just because they happen to be out of state, that's one thing. If they are usually out of state, that's fine if they can if they're able to make a referral to a Virginia-based provider. Otherwise, the expectation is that they maintain a practice located in Virginia. But so if either of those conditions are met, then that is allowable. But for those who are considering this out of state, do be aware of this stipulation about the ability to then refer to a provider in state if the distance site provider is located out of state.
And also it would be good to follow up with your licensing board in case there are nuances with licensing. I know as for behavioral health, when we reached out to Department of Health Professions, their kind of rule of thumb is the licensing requirement usually follows where the client is. rather than the licensee. So if the licensee is in another state, they can continue to treat Virginia clients. But if the client is in another state temporarily, it really depends on the other state's requirements. So where Medicaid may not be specific to something, it would also be good to follow up with your licensing board. There's a question, and I believe we've responded to it in the Q&A. You mentioned about recording. What provisions do you suggest if we discover the patient is recording their telehealth sessions?
No guidance. We'll let you know if we hear about any best practices.
Are there specific programs for telehealth, or can we continue to use Zoom or Microsoft Teams?
During the federal public health emergency, the flexibilities will apply to those. After that, again, that would be a question of ensuring whether they meet all the HIPAA and other kind of state federal requirements for confidentiality. If the platform that you are using meets those, then as a payer, I don't think we would have that would. If it's meeting those requirements, then there would be no issue on our front. But certainly make sure that it meets those requirements after the end of the federal public health emergency.
This is John. I'm going to address a question that's come up in the Q&A. It's a great question. It's around a very specific use case. The use case that was described was if our provider is working not in the office, say from home, and a member were to come into the office to have a Zoom call set up with our provider who is working remotely, could we bill the originating site fee for our efforts to set up the member to receive telehealth? The answer I gave is no. The answer kind of why not was asked, and I will say we may need to update our policy to clarify this. But seeing as the intent of the originating site and frankly of telehealth flexibility is to ensure that we reduce member barriers to access, but frankly, not necessarily provider barriers to getting into the office, it would be inappropriate. And I'm not sure if I'm saying this, if I'm explaining this very well, but suffice to say, if telehealth is being used to substitute for the provider being in the office, DMAS would not find it in any situation appropriate to provide additional compensation for that office to essentially accommodate their providers from being able to bill wherever they want to be. So we will be happy to potentially add language that clarifies that would be an inappropriate use case. An appropriate use case may be the following. If a patient is attempting to receive services from a specialty provider who is across the state or for whom they are unable to visit an office, but they do not have technology at home to use and therefore kind of engage in a telehealth evaluation, that patient could visit their, say, primary care office or a local Medicaid biller, and they could allow that member to use their Zoom telehealth setup to then access a service that is being provided not by a provider within their own walls or within their own practice, but by a separate provider, a cardiologist from across the state. So that is the intended and appropriate use for that originating site fee, is if you are providing telehealth access to a member to receive care from a provider not within your own practice. That would be an appropriate use, as opposed to having the patient come to you, you provide services for them to access your own provider who just so happens to not be in the office but at their home. So that would be an inappropriate use case, and we can clarify that later in writing.
Thank you, Dr. Morgan. Another question, are there any considerations around technology discounts for families who desire to use telehealth but do not have the funding to purchase equipment?
Great question.
Mhm.
Unless Andrew or Ashley know better, there are no current plans or coverages in place that would necessarily deliver telehealth, equipment to a member, but we agree, we see that problem. It's a concern of ours. We are working to find ways to increase access to appropriate technology and broadband. And the second use case I just provided around originating sites is a type of workaround, although we agree that is only probably relevant in a handful of use cases and it's not a perfect solution. But in short, no, but we agree it's a problem and we're trying to find ways to address those barriers.
And that might be, too, I know during the public health emergency, the majority of our members enrolled in Medicaid are going to be covered by a managed care plan. And some of the managed care plans were able to do some enhanced services around access to telephones to be able to communicate with their medical provider. So that might be if you have a particular individual that you're working with that's really struggling and needs that connection, to reach out to the Medicaid MCO. They have care coordinators that are available to see if that's something they could potentially help with. Another question, can telehealth services be delivered for therapeutic day treatment? And I will also throw in intensive home services to a child under the age of 14 when a parent may be at work or another adult is not in the home? And the answer to that is yes. Question, can you provide or can you confirm place of service O2 for telehealth? Should that be used along with the telehealth modifiers?
Andrew, and there's a second question on the place of service that we can take together, and that it said in the March 19th memo, it does advise for behavioral health providers to use place of service code O2 and to reflect telehealth delivery, as this will be required at a future date. As the situation has evolved and where we are now, our guidance as put forward is to not use place of service O2, but to use again, the GT or TQ modifier and the place of service where that encounter would have taken place. I'm happy to, since that's a really good point about something that was communicated in an earlier memo when the COVID-19 pandemic had just hit. I think this is worth us putting into an FAQ just to document our approach going forward and to make that clarification. So thank you for both those questions.
Another question around intensive and home H 2012, is that being included or approved for utilizing telehealth moving forward? And yes, intensive in-home services are listed on the services that will be approved for telehealth post the public health emergency. Are federally qualified health centers able to be the distant site providers?
Yes.
Mm-hmm. Very good. Psychosocial rehab services. Will there be a max unit bill for telehealth services post the public health emergency? That's a great question. When we're seeing for the behavioral health services, services being delivered in person versus services being delivered via telehealth. As long as they're meeting all the requirements, then you would bill it just as you would in-person services, but it would have to meet all the requirements that Andrew captured in the presentation today. Another question, and Andrew and Dr. Morgan, you may have answered this. Around the originating site fee again, is that something, do you want to address it as far as can it be charged at the provider by the providers if the provider's office is the originating site, but the provider, let me read.
Yeah, I think
I
I
think
Bob's
wrong.
question.
Why don't we take these back? Since this has come up a couple times, we'll take this back. We'll consolidate and then provide an FAQ on this.
Okay.
It's a great point of clarification.
Some others around the place of service, so too.
I'll just address Marcy's question about Medicare telehealth coverage. Yes, we're not experts, but I would say we have studied Medicare's telehealth coverage policies extensively, and our goals have been wherever possible to align our approaches to covering telehealth, as well as the services that we cover via telehealth. We've attempted to align those with Medicare's wherever possible. It's admittedly not always been feasible or possible, either because of differences in historical billing, claims, policies, as well as flexibilities that are often available to Medicare that may not be available to Medicaid. But yes, we have definitely studied Medicare's coverage policy and attempted to align ours with theirs wherever possible.
And then we have another question to confirm that 90837 and 90791 are included in telehealth policies going forward. And I'm again bringing up the May 13th, 2014 memorandum. And you can see here those procedure codes are listed. It falls under individual psychotherapy and the psychiatric diagnostic interview.
And then just to clarify, if one were to refer to the telehealth supplement that is posted for public comment, that table of services, or there's actually two tables, one with clinical services, one with behavioral health services, that would be inclusive of all the services, both from 2014 and new services. So that's probably the appropriate document to refer to ensure that the service that you are interested in is there or not there. But that is the more authoritative. At this point, the authoritative list is what is being posted for public comment.
So another question, if we provide telehealth platform to assist the member in receiving services and the provider is at a remote non-office site, could you then bill the originating site fee?
Again, let's wrap this into our originating site FAQs so that
Okay.
We don't misspeak on the phone.
When does the current public health emergency end if federal doesn't extend? Or when do they plan to announce the extension?
I think actually, let's see. I think if we're talking federal public health emergency, they're authorized in 3-month increments. I think you said July 20th or so. And as Ashley noted, we usually receive word a day or two before, and at that point, a Medicaid memo would be issued indicating that the federal public health emergency has been extended.
Another question, do you happen to have any knowledge about Medicare telehealth coverage?
I think John
Answered
referenced that already.
Yeah. Andrew and Dr. Morgan, I believe all the questions in the Q&A have been addressed. I'm going back to the chat function. Is there a modifier for telehealth services delivered by a licensed eligible clinician under supervision of a licensed credentialed staff? So that's like, I think, looking at modifiers provided by a resident in psychology or psychiatry or in counseling or supervisee and social work?
I would love to have that modifier. We do not currently have a modifier that would do that, and by extension, we do not require use of any modifier to denote that situation. We would love one.
Another question, in the supplement are the new behavioral health enhancement codes that are going into effect July 1st being reviewed for inclusion as appropriate. So the answer is yes, that the services that are going live July 1st are assertive community treatment, mental health intensive outpatient, and mental health partial hospitalization programs. And those are all included in our telemedicine policy going forward. And a question going back to the use of residents and supervisees, that is still allowable. They would just be billing under the agency NPI or the licensing supervisor that's on site.
And just so for those who are still on the line, just so you know, I just put into the chat the telemedicine mailbox that has been set up at DMAS, VA telemedicine at dmas.virginia.gov. Please feel free, if we have not been able to address your question here, or you have it, and I think Ashley did the same thing as well. Please make use of that, and we will get back with some answers to any questions that you have. So I think, are we petering out on questions?
I think so.
So I think we will, first, thanks. Yes, wonderful questions. Thank you so much. We appreciate everyone's interest in this and your questions. Again, we will compile these into a FAQ kind of format and find a way to communicate that information back out. And as always, just to reemphasize, please do make use of the email vatelemedicine@dmas.virginia.gov if you have any remaining questions, and we will be sure to address them. So on behalf of my colleagues, thank you so much for your time. Enjoy the rest of your day, and we look forward to moving forward with telehealth. Thank you again.